Thank you, Dr. Bonham and Dr. Cobbs. And first of all, I just want to say I'm honored to be here today and to be invited to speak to everyone and share the role of social work in glioblastoma patients. As Dr. Bonham said, I am the longest tenured, along with Dr. Cobbs, staff member. I've been there for 4 years, have enjoyed every day of working with these patients. And one of the things that I've learned over the years, I have been a social worker for over 30 years, and one of the things that I've learned about what families need, what patients need, is a lot of times they just need space to be held for them and to meet them where they are. Each patient that comes in the Ivy Center, although they might have the same diagnosis of glioblastoma, comes in at a different time in their lives where we just need to meet them where they are, listen actively, and provide that emotional support. So today, my objectives are to demonstrate key roles for social workers in GBM care and identify how family dynamics impact GBM patients. The way I'll show the identification of the dynamics from the family is I have two vignettes I'll share with you at the end to kind of identify how social work has collaborated with the rest of the neuro-oncology team to meet the needs of the patient and their families. So I wanted to give just a little tiny bit of history about social work that began way back in the 1840s and 1850s with volunteer-supported efforts primarily surrounding poverty. And social workers started off as volunteers to go out into the tenements to help families. And from that initial volunteer support, today, social workers like myself have a master's degree in social work. We are licensed. We sit for a national board exam. We have about 3 years of supervision that we have to fall under another licensed clinical social worker before we are able to become a licensed clinical social worker of our own. So all that to say, we use our clinical knowledge, skills, and abilities to help our patients and our families. And just a little aside, I wanted to share a quick story that I worked in another healthcare organization. Again, I want to remind you, I've been a social worker for 30 years, but we were in morning huddle and talking about a patient in a family that needed assistance. And one of the providers said, "Oh, Brenda's going to go and sprinkle her magic pixie dust over this family and magically fix what's happening with this family." And of course, no malice was intended. He was not meaning to diminish my skills as a social worker, but we did do a gentle reminder that we do take a look at these families, we complete our assessments, and then we help with the family to decide what to prioritize to decrease their stress. So I just wanted to say, I know there are some days, and Dr. Bonham, Dr. Cobbs, you probably feel this way, that we do wish, some days we did have that magic pixie dust to sprinkle over these families who are getting this devastating diagnosis of glioblastoma. There's panic, there's shock. The first thing the families tell me is they feel like they've been hit by a bus or possibly been pushed off of a cliff. They just have no reference to imagine that they would ever get this diagnosis. One of the things that I love that Dr. Bonham does, I do go in and I sit sometimes with our new patients and with Dr. Bonham. He'll provide comfort to them to say, there's nothing that you've done to bring this diagnosis on you. Sometimes families feel guilty or patients feel guilty or wonder if there's something that they did in their past. Did I smoke? Did I do something? And he reminds them with a gentle reminder that there's not anything that they've done. So that's a good starting point for these families to feel that, this is just a bad luck situation. So again, talking about initial assessment tools, as social workers, what we're going to do initially with all new patients, again, we're going to meet patients where they are. We're going to screen, assess, triage, intervene, and then I think one of the most important things is to monitor, to check back with these patients over the time that they're coming into the Ivy Center, either at their 2-week or 4-week follow-up, 4 months, 6 months, whatever it is, we're going to be there to monitor their needs. Some of the tools that I use to help our patients is with the general anxiety disorder, the GAD-7, the PHQ-9, which is the patient health questionnaire for depression. And finally, I'm going to talk about the real crux of the tools that we use as social workers in oncology care, the distress screening tool. But the general anxiety and the patient health questionnaire, these are questionnaires that we use to ask patients over the past week what their experience surrounding anxiety and depression are. So we take that into account, that this is just it's over the past 2 weeks. Over the past 2 weeks for the general anxiety and patient health questionnaires. So we already know that families are going to come in already with some stress, some level of stress, knowing that they've had a craniotomy, they are waiting for their final pathology to determine, or maybe they already know that the diagnosis is glioblastoma. So we're going to expect some type of anxiety. But if they do have anxiety that is not manageable, maybe they do need some medication for that. That's something as a team we're going to look at, and we are going to connect them with some behavioral health services. One of the things through the Ivy Center that we are very, very lucky to have is that we collaborate with the Swedish Cancer Institute. The Swedish Cancer Institute over at First Hill has a psychiatrist, Dr. Adam Hinsey, who can see patients about 5 to 6 times. It's a brief therapy that he will see patients who are experiencing issues of anxiety and depression related to their cancer diagnosis. What we'll do is after he's completed with his 5 to 6 sessions with them, as social workers, what we do is we then connect the patient to community-based behavioral health personnel so that they can continue to get ongoing and long-term therapy that they need. So again, 2 of those tools, the GAD-7, PHQ-9, assessing anxiety and depression. But really, where I really get a sense of how the patient is doing and how I can best serve their needs is through this distress screen. Some of you might have seen it. It's the little, I did my best with my cut and paste to put the distress screen up here. But it looks at the following issues. It looks at physical concerns, emotional concerns, social concerns, practical concerns, spiritual or religious concerns. And then the nice thing is there is a little blank space where families can go in, or patient or family can come in and identify any other particular need that they have. So you see the little thermometer there. They circle that, color it in on a scale from 1 to 10. So based on that level of distress, I know how to help them, again, prioritize what are your current needs that we really need to manage. Many of our patients, we see patients throughout the state of Washington. We have patients coming from Alaska. So because we see patients throughout the state of Washington, they might not always be near a center where they can come and get radiation. They might have to travel. So one of the things that I'll do is I'll meet with the families and we'll develop a plan for transportation. That's one way of decreasing their stress if they don't have family to support them. So depending on what they're identifying, how they're marking that scale from 1 to 10 is where I'll meet the patient where they are to help reduce barriers to care and to support them any way that I can. One of the things that I do when I first meet a new patient is I have a little, it says social work services sheet, and it has my name, my contact information, my hours, my office hours, all the information that they need to connect with me is on this form. And I've highlighted some of the things that you're going to see in bold are a lot of I would say those are the services that I provide most or that patients ask for when they come to see social work. So one of the things is the Superior Port resources is that I do facilitate a brain tumor support group twice a month, and it's for patients and families. So if the caregivers come in, that could be the spouse, that could be, we've had adult children participate, we've had other caregivers, other family members come in. But one of the great things out of that support group is that the patients come in, they meet with each other twice a month, they get to know each other, they establish this bond. And sometimes the patients themselves will meet outside of that group on a one-to-one session. I've had a couple of patients who have, on their own, go out to coffee, They go to dinner, their families meet each other. And what they say that brings the most comfort to them is that this opportunity provides them an opportunity to speak shorthand to someone else. We knew a couple of gentlemen who were both wearing the Optune, and they could speak shorthand to each other about maybe some of the issues that they have regarding, or, maybe some of the situations that they have. And so that was some way that they could talk to somebody one-on-one who really understands. And at each of the support groups that we attend, off the top of, if we have a new patient coming in, off the top of the group, I will share that I am the facilitator. The group is their group. They're going to discuss the issues that they can, because I don't have a full understanding, as I've never had that diagnosis, of what they're going through. And these people talk to each other in shorthand. And throughout, I operate it via Zoom. Throughout that Zoom group, I just see this understanding and this acknowledgement of each other over that interaction. So that's one of the things that we can do, social workers can do, is connect folks to each other. One of the biggest roles that I have as a social worker in oncology care and with our GBM patients is the family medical leave. In the state of Washington, we have the Washington Paid Family Medical Leave, and then answering questions and helping folks with Social Security disability. I will tell you, I did a little informal survey of my support group that it held on Tuesday. And I said, when you first got that diagnosis of glioblastoma, what was the first thing that came to your mind? I'm going to tell you, I honestly thought it was going to be about finances. I thought folks were going to be talking about, how am I going to support my family? How am I going to work? And of the small group that I had 5 patients attend. They all said the first concern that they had was for their family and for the burden that they were going to be placing, they felt, on their family. And that really surprised me. I thought it was going to be more of a practical nature, and it wasn't. It was more emotional. One gentleman said he felt guilty. He felt guilty that he was going to be a burden to his wife, and he felt guilty that he was going to not be able to do his job as effectively as he had in the past. He absolutely loves his job. He's still there now. He's working a very, very part-time nature. But when, again, in this patient support group, when they said these things of feeling guilt, feeling shame, if you will, regarding this diagnosis, something, again, as I reminded you earlier, nothing they brought on themselves. These other people in the support group, again, held space for them and listened, no judgment. It was, everybody could share what they wanted, but it was just a beautiful thing. And I wanted to share that because I thought it was surprising from what I thought was going to be the primary concern. One of the things that in that third section down, the quality of life resources, one of the things that we do as social workers is we connect families to caregiving, to home health services, to hospice. And one of the things lately that Dr. Bonham and I have really been seeing a little uptick in is folks asking about the Washington Death with Dignity, or medical aid in dying. So over my 4 years, probably we've had about 12 patients ask to use this law. And our role at the IB Center has been, Swedish's policy is that the physicians can decide on their own if they want to discuss the Death with Dignity Act with the patients. If a patient brings it up, what I found with Dr. Bonham and then our previous neuro-oncologist, Dr. Kester Phillips, is that they have a willingness to talk to these patients about some of their desires to use medical aid in dying. The role that we play in the IB Center with that is that we would act as the consulting physician in that role. What we're doing is we're confirming diagnosis and we're confirming prognosis. And we're adding a sentence in the progress note that indicates that the patient has asked for their first verbal or has made their first verbal request. And then what that does in the state of Washington, that starts the process. So one of the things that, like I said, I'm very appreciative to work with Dr. Bonham on this is that we collaborate to talk to the families about this, about the law, if they want to use it. We start that conversation with them, and then we refer them to End of Life Washington, who are the subject matter experts who can talk to them, who have videos, who have volunteers. So although patients bring that to us. Our role is to put a note in the record, to do that consulting physician form confirming diagnosis and prognosis. And in the state of Washington, that medical aid in dying is 6 months or less prognosis. And folks have the ability to use that. So just wanted to share that with you and kind of the role we play and how social work collaborates with and helps coordinate that. The big thing we see, advanced directives, living wills. And I try to normalize this for patients when I first meet with them who come in and don't have advanced care directives, which would include a living will, a durable power of attorney. And so they're already anxious and nervous about their diagnosis and prognosis. So I just try to normalize it and say, this is something all of us should have. It's not just because you have this diagnosis of glioblastoma. This is good business for all of us. So if you have other family members who need these forms, I'm happy to give you extras. So oftentimes I'll give an advanced care directive to a patient, and they ask for 3 or 4 more for their adult children, for their neighbor, for their whatever it is, because I really do talk to them about the importance of having these forms in not only completed, but somebody else knows about it and they know where to access it. So the patient has completed it, has notified their family, has put it in a place where somebody can access it when needed. We have the portable orders for life-sustaining treatment. We usually see that form completed with their primary care physician. We don't see it as much in our clinic, at least, but that is that form that's completed on a bright green form. It's part of an advanced directive, so we do ask that folks complete it as they can. Most likely they'll do it with their primary care physician. Again, the support groups are, I can't tell you the benefit that I see of support groups, again, for both the patient and the family. And over the years, the camaraderie that has been built with those folks, with each other. And I'm not a psychotherapist. I'm a social worker who's been trained as a case manager all my life, all my 30 plus years, more of a case manager. So the support group is more of a true support group with additional resources that are talked about. So anything that the support group talks about, I send out in an email the following week, because patients are doing their own research. Patients are looking at American Brain Tumor Association website. They're going to, their children are involved in camps and activities. So anything they share, I move forward and I share with the rest of the group. This one. So thinking of the list I just showed you of all the things that we do with our patients, I'm going to just real quickly talk about Mr. B. Mr. B was a 61-year-old gentleman who was on the verge of retirement. He had a spouse and 2 teenage daughters who wanted to know about his glioblastoma diagnosis in very different ways. One daughter wanted to know everything. We arranged through Dr. Cobbs for her to come and do a tour of the IB Center lab. That's how interested she was in her dad's diagnosis. The other daughter didn't want to know very much. She said after each MRI, this is all she wanted to know. Thumbs up, thumbs down. That's all she wanted. So Mr. B's spouse had some anxiety surrounding his prognosis. So we met oftentimes with our physician assistant off schedule from the neuro-oncologist so that we can provide extra support for this family who was really struggling with anxiety regarding this diagnosis. Mr. B was one of the patients who met with another patient who were about the same age, had similar work issues or similar work. But again, we just met this family where they were. Each time they reached out to us for help, we found a way to provide them support. We found a way to support the daughter who wanted to know everything about this diagnosis and how to then support the daughter who didn't want to know very much at all. Quickly, Mr. W., young gentleman, finished school, just finished his degree, comes from a cultural background where Western medicine is not the primary choice for this family. So one of the things that we've done is that through Dr. Bonham and I, we worked with the Swedish Cancer Institutes. They have a cultural liaison. And I met with her to talk about this particular case. And one of the things that she told us about this gentleman and his culture was that oftentimes we use the term, I used it at the top of this of my talk, is good luck and bad luck. Maybe we talked about, he had the type of cancer, glioblastoma, that was good luck, or bad luck that would respond better to the standard of care. So through that interaction with the cultural liaison, we changed our verbiage in how we talked to this individual. We met with his family with an interpreter to have them have a better understanding of what the diagnosis was. A lot of anxiety with this patient. We've made multiple referrals to cultural appropriate behavioral health support. He's not ready to engage. So each time he comes, we meet him where he is. We don't push. We offer, again, hey, just a gentle reminder, these services are available. Okay, I'll think about it. Oh, just a reminder, palliative care is also available. Yeah, make the referral and I'll think about it. We never push. We never try to force anything on this patient or his family. We act as listeners. We meet them where they are, and we collaborate as we can with outside community resources to provide support. And again, the goal, decrease stress for this family. Thank you. I hope I've given some information just kind of about social workers by nature are collaborators. So everything I do with the patient in mind and with the plan of care from Dr. Bonham. So it's always in a collaborative nature, and I do what I can to help our patients to manage this horrible, terrible diagnosis. Thank you.
Brenda, thank you so
much.
Thank
you.
I think it's critical that we think about what we're doing all this research for, and it's all to help these patients and their family members get through this tough time. So I'm going to move on to the next speaker, and before I introduce him, since I've never met him,